Okay. Dr. Nkanta has a question, so let's give him the floor to answer the question quickly.
Okay, thank you very much, Dr. Obaro. It was a very interesting, enlightening, and educative presentation. The issues we have now, especially in obs and gynae, we have maybe a lot of differentials. Seeing some of the patients we manage also come with fever, pleural sepsis, post-op, and then with the eclamptic patients. The problem we have now is that initially you can get results within 24 hours. And now from the information I've gotten, even in Bauchi, in fact, they say nationally we don't have test reagents to screen for this disease. So I don't know if you have a case of suspected, like in my department now, if you have a case of a probable Lassa fever, we start the recovery straight. So I don't know in this situation, how do you think patients should be managed, sir?
All right, thank you for that question. Yes, just like you said, is a national challenge presently. Initially, NCDC was doing very great, reagents were coming in, but of recent, there have been challenges. The past 3 weeks, we have been trying to struggle to see how we can get reagents. Formerly, when we run out of reagents, we send our samples to Bauchi. But even the Bauchi that we send the last samples to, they said they don't have reagents. So we'll keep pushing, we keep pressing. And that's why you need to know those 4 different categories: alert, suspect, probable, and confirm. So like you said, if it's a probable case, we are in the right path, the right track to commence the recovery. Why we keep pushing to see how NCDC will give us either reagents or approval to send our samples to either National Reference Lab or Bauchi or Edo State, like we used to do in the past, whereby we can do the test. Thank you very much.
Okay, thank you for the explanation given. I think we need to double our efforts as a country to ensure that we stop, Lassa as fast as possible, or rather to make sure our patient gets prompt diagnosis and treatment. So we'll go straight to the third and the last presentation of the day. And that is recognizing Leucocoria and the benefits of early intervention. And that will be taken by Dr. Amos Nyiokes of the Department of Ophthalmology here at FMC Jalingo. So, sir, you have the floor and go on with the presentation. Thank you.
Thank you very much. You're welcome to the third presentation of the day. And I will present the topic of recognizing Leucocoria and the benefits of early intervention. I will use the following items. We'll talk about some relevant anatomy, introduction, common causes of leucocoria, then how to recognize leucocoria, and some interventions and benefits of early intervention, and then we'll conclude. This presentation, at the end of the day, is expected that we become conversant with leucocoria, and we are able to identify and send patients to appropriate places in a general note. So, anatomy of the eye. We know that the eyes are paired organs used for sight. And we have the eyeballs that are suspended in the bony orbit, the anterior part of the skull. They are connected to the brain via the optic nerve. Other contents of the orbit are extraocular muscles, nerves, ophthalmic vessels, branches, orbital fat, and others. Look at the diagram here, the picture of the eyeball, which is sliced to show some of the structures that are inside and how those that make part of the wall of the eyeball. The eyeball has 3 layers, main layers. The external sclera, that's the most external, which forms the posterior 1/5/6 of the eyeball, and the fibrous layer, and it continues with the cornea in front, which forms the anterior 1/6. And then just under that layer is the intermediate layer, which is the uveal tract, made up of the iris anteriorly, which continues with the ciliary body, and then the choroid that surrounds the retina. The last layer, major layer, is the retina, which surrounds the cavity, vitreous cavity. The lens is suspended by ciliary muscles behind the iris and the pupil. The eyeball contains the anterior and posterior chambers and the vitreous cavity. These are fluid-filled spaces. The vitreous is, of course, more viscid, and all the fluids are clear so that light can pass from front of the eye to the back or outside to the back. And that is why we talk about ocular media as the clear space from the cornea to the retina through which the light passes to the back of the eye. With that brief introduction of anatomy and probably physiology, we will look at leucocoria. And by introduction, leucocoria refers to white pupillary reflex. Normal pupillary reflex is red, and this is because of the reflection of light on the choroidal vessels. Leucocoria should be differentiated from corneal opacity. Commonly in the clinic, sometimes people write referral and we see corneal opacities being labeled leucocoria or cataract. And so from anatomy, we know that corneal opacity affects the cornea, and the cornea is the front. It is in front of the anterior chamber and the pupil and iris, while leucocoria occurs within the pupil, which is bounded by the iris. Identifying leucocoria early may help improve visual outcome of treatment and reduce morbidity and mortality from systemic diseases. We are to note that leucocoria may be a late sign of some diseases. So if a patient comes with leucocoria, it doesn't mean that we are catching the patient early in all circumstances, because that may be a sign of late presentation in some instances. Now look at the diagram here, or the picture. It shows leucocoria, which we said is white pupillary reflex or yellow-white pupillary reflex. And we have dilated pupils here. One has very white pupillary reflex, while the other one is a little bit dull, but we are having leucocoria. And this is caused, in this case, by cataract. Now, some causes of leucocoria include cataract, retinoblastoma, retinopathy of prematurity, retinal detachment, toxoplasmosis, infestation, and toxocariasis, Coats disease, persistent fetal vasculature. How do we recognize leucocoria? Of course, we need one, the knowledge of, the anatomy of the eye. As we said, the pupil is at the center, usually, and is bounded by the iris. And it's usually round and reacts if briskly to light, if it is normal. So the knowledge of the anatomy will help us to recognize it and differentiate it from other differentials like corneal opacity. What tools do we need? For us as general practitioners, a simple pen touch is important, a source of light. Once we shine light on the eyes and we see a white pupillary reflex, of course, we have a diagnosis of leucocoria. Ophthalmoscope is one of the things or instruments we use, and we have direct ophthalmoscopes. Both have their advantages and disadvantages, but most times it's used in the eye clinic to have a detailed examination of the posterior segment to identify the location of possible location of what is causing the leucocoria and staging it, of course. On what to do when we have a patient with leucocoria. Of course, leucocoria, we have said that there are many causes of leucocoria. So it is important for us to take history. History taking, of course, is important, physical examination, and some investigation. This may not be applicable at all levels of care due to facilities and the issue of expertise. So, if we have history, the age of the patient is very important. The sex, most cases of leucocoria, of course, occur in children. Children are more predisposed because most of the diseases that actually have been taken care of, prevented, usually occur early in life. For the sex, sometimes some diseases have predilection to female or male sex. Then the duration of the leucocoria is important. And history of ocular injury and in children, of course, history of pregnancy, delivery, and the neonatal period is very important because these events can uncover some clue concerning the possible diagnosis of a problem or the cause of leucocoria. So, when the patients can tell you about whitish speck in one or both eyes, and family history of similar problem, important, because as may be seen later, some diseases have genetic basis, and so they are clustered around some families. So, developmental history of that patient is important. Then, history of consanguineous marriages, marriage between relatives, because for genetic problems, it can enhance progression and distribution through the family line. Living with domestic animals like cats, dogs, are some aspects of history that are of importance. Now, when we examine the patient using some of the basic tools we mentioned there, general examination, of course, we would do, that will give a clue to some of the problems that are systemic, that manifest with Leucocoria. And so even some systemic examinations can be performed. Ocular examination, of course, we start with the visual acuity where possible. Visual acuity may be deranged, of course, in most cases, but the fact that some of the children are very small, it might be difficult to do a proper visual acuity. And then we examine the anterior segment or pupillary examination using the tools we mentioned earlier. We are to note the clarity of the cornea, as I mentioned, because if the cornea is opaque, and sometimes it might be confusing. So we use our anatomical judgment in that case. The pupil size, the activity, the regularity of the pupil. I said the pupil is supposed to be briskly reactive, round, and about 3 to 4 millimeters in size, and should be regular, not irregular. The lens should be identified, usually lies behind the pupil, and it could be clear, or you can have opacity of the lens, either in isolation or in conjunction with some other changes. It is important to note here that leucocoria usually occurs following diseases that affect the lens, the vitreous, and the retina. So, and the ones mentioned earlier actually implemented the cause of leucocoria. Will not any yellow-white reflex, of course, within the pupil, and dilated fundoscopy, of course, might give us more access to examination of the posterior segment. Examination under anesthesia in children is important because they may not cooperate for proper examination. And examination can give, proper examination can give a clue or can give us diagnosis of the cause of leucocoria. Some investigations that assist in recognizing the cause of leucocoria include ocular ultrasound scans. Scan can reveal swellings or tumors or calcifications and the location in the eye. Computed tomography scan will also give us information about the integrity of the cords of the eyeball and where the leucocoria possibly is coming from. And we have optical coherent tomography. This can give detailed slices of the retina and other parts, including the vitreous, and it can help us to identify the cause of leucocoria. Skull X-rays sometimes can reveal calcification in some tumors. some other investigations like erythrocyte sedimentation rate and eosinophilia in parasitic infections and now causes of leucocoria where early recognition can benefit the patient. The first one is cataract. We know cataract as a common cause of leucocoria, even in adults and children. And it's the commonest cause of blindness worldwide. So it's a very important problem. And it refers to the opacity of the lens, as we saw earlier. May occur at birth. Cataract may occur at birth, and that is congenital, or at any age. Now, there is a repeat of the picture of the cataracts of different intensities here, as seen in this slide. So, during childhood, light stimulus is critical to visual development. And that is why the young is or children are very, very susceptible to blindness from, especially the young ones, the infants and the under 10. They are susceptible to visual loss from cataract. When the lens becomes opaque, it can impair visual development, especially the critical weeks of development or period of development. Within the first 1 year, if a patient has cataract, especially in one eye, or it can happen in the two eyes, it can develop a situation we call amblyopia due to stimulus deprivation. Because, as I said, the retina needs light to develop vision. So once the ambient light is not enough, of course, because of an opacity that is obstructing, the brain can forget about its development. Amblyopia may become irreversible if neglected until 10 to 12 years of age. So, therefore, children who have unilateral or bilateral cataracts, few weeks after birth, are considered emergency cases. Cataract surgery has to be done as soon as possible to enhance visual development and prevent blindness because of restoration of the ocular media, as we mentioned earlier. Now, screening of newborn babies for leucocoria by health workers will enhance early detection and referral to ophthalmologists for prompt treatment. We mentioned that some children are born with cataract. We frequently see, and sometimes we see babies coming after 1-2 years, and they were told that they were too young to go to see the doctor. So they decided to keep them at home. By the time they come, the eyes are already bobbing with nystagmus, and that's a bad sign of visual obscuration. School screening program educating teachers on how to detect abnormal reflex will be important, because sometimes some parents may not be that careful, but if they send them to school, the teachers, if they are able to notice any whitish speck or cat eye reflex or abnormal reflex in the eye, they will quickly notify the parents for proper action. Apart from amblyopia, which results from delayed intervention, very old cataracts can undergo degenerative changes, becoming hypermature. And if a cataract becomes hypermature, the possibility of lens proteins leaking out of it, intact capsule, to cause uveitis is there, or inflammation within the eye, with possibility of developing glaucoma. Now, the other important cause of leucocoria that early detection may abort a sinister scenario is retinoblastoma. It is a common congenital malignant tumor arising from neurosensory retina in one or both eyes. It is the most common intraocular tumor of childhood. Up to 1 in 20,000 live births can be affected, and occurs commonly under age 3, though it can occur late, especially in the diffuse infiltrating type, which has no sex predilection. About 25 to 30% of cases are bilateral. This is a picture of leucocoria that results from retinoblastoma. And it might be difficult for one to differentiate it from that of cataracts. All of them lie within the pupil. But sometimes careful examination will see some vessels that are growing on the surface of the mass within the eye. Genetics and heredity of retinoblastoma. The retinoblastoma gene has been identified, and it lies on band 14 on the long arm of chromosome 13, and is a form of cancer suppressor gene, or anti-oncogenic gene. Sorry for the deletion or activation of this protective gene by 2 mutations, as proposed by Knudsen, and the 2-hit hypothesis has been thought to result in the formation of or occurrence of retinoblastoma. Now, the hereditary form of familial cases, and that the first hit, as we said, there are usually 2 hits, mutations. The first hit occurs in the parental germ cells before fertilization. So it's actually inherited from 1 or 2 of the parents. Therefore, it is transmitted to all cells, including somatic cells, and the risk of non-ocular tumor, therefore, rises. The second hit occurs later, after fertilization, and it affects the second allele on the band 14 of the chromosome, long arm of chromosome 13. The hereditary cases account for 40% of all cases, all bilateral cases, and 15% of unilateral cases are hereditary. So, and they are mostly multifocal, and there are trilateral forms in which you have retinoblastoma with pineloblastoma. Inheritance is autosomal dominance, and risk of transmission of mutation is usually up to 50%. Because of high penetrance, 40% of offspring of a survivor of hereditary retinoblastoma will develop the tumor. 40% chances of developing tumor in sibling of a child with bilateral retinoblastoma. The non-hereditary type, in that both mutations occur in the embryo after fertilization, and accounts for 60% of all cases, and they are mostly unilateral and unifocal. Now, the presentation of retinoblastoma, as we mentioned, leucocoria in early cases, is one of the main presentations. But there are other presentations like squint, masquerade syndrome, uveitis, and then late presentations like orbital inflammation and then fungating mass can occur. The place of early recognition of leucocoria and benefits is one. Treatment options like enucleation may cure disease if there's no metastasis. Now, the modalities of treatment are many, but if the tumor is still confined to the globe, and careful enucleation, which entails removal of the globe with part of the optic nerve, may cure the tumor completely, and that might prevent mortality, and that also may save some medical bills. Now, if we look, we will see pictures of, this is a fungating retinoblastoma, and then these two are patterns of growth of retinoblastoma, usually starting, as we said, emanate from the neurosensory retina, and they can either grow through outward towards the subretinal space, or they can grow into the vitreous cavity. The first one there is growing into the vitreous cavity. That is an endophytic type, while the exophytic type, which frequently causes retinal detachment, as you can see, is growing outward towards the subretinal space, and then it's pushing the retina and causing retinal detachment. There is also another pattern of growth, which is diffuse infiltrating type, which follows the course of the eyeball. That one, recognition is usually late, as I said. Treatment options, as we mentioned, cryotherapy, brachytherapy, this external beam irradiation, enucleation, chemotherapy, exenteration, radical exenteration. And then we talk about gene counseling, because it's genetically important. We need to do genetic counseling. Couples that have children who are afflicted with retinoblastoma may need to reduce their family size. Okay, stop producing more children. Maybe advise to stop producing more children because of likelihood of retinoblastoma, and then educating them on screening early. Other causes of leucocoria, as we mentioned earlier, we will mention a few of them. Retinopathy of prematurity, which also occurs in children, is a bilateral proliferative retinopathy occurring in premature infants, which usually have low birth weight and who are often exposed to high oxygen concentration. Staging, of course, from stage 1 to 5, as you may see later in the diagram. Now, it is important for us to screen premature newborns who are at risk, preferably 6 to 7 weeks after birth. We'll do a fundoscopy with indirect ophthalmoscopy. Indirect ophthalmoscopy, dilated indirect ophthalmoscopy. And that might reveal early stages, stage 1 and 2. The first stage actually is a demarcation line, and the stage 2 is where you have a ridge that's forming already. In these cases, we need to observe the patient. Now, these are the various stages in diagram. Though it might not be very clear, the first one there is the stage 1, where you have a demarcation line, and then you have a ridge that is formed there. When here, those are fasties. And then you have proliferation of neovascularization occurring. And then the fourth one there, you are already having a retinal detachment, including the macula from fibrovascular proliferation. The last one here is complete or total retinal detachment. Okay. Others are infective, toxoplasmosis, as mentioned earlier. It's caused by a protozoan infestation. The protozoan is Toxoplasma gondii. The cat is the definitive host, and human beings and other animals like cat, sheep, pigs are intermediate hosts. And the disease has predilection for brain and retina. Congenital cases are transmitted via the placenta to the unborn child, while those rarely acquired cases are thought to result from eating undercooked meat. Features include convulsion, chorioretinitis, and intracranial calcification. Ocular features. Why we see this leucocoria is because of necrotic granulomatous retinochoroiditis involving the macular region in most cases. The ones that are peripheral may not be blood. And this results in leucocoria. Of course, treatment, topical steroids, systemic steroids, and then sulfadiazine, pyrimethamine, all those are drugs that can be used there. Another infection is toxocariasis infestation. This one is caused by Toxocara canis, a roundworm of dogs and cats. The children are predisposed to this because they usually play with dogs, cats, and sometimes eat dead. And they ingest ova of this worm, which develop into larvae in the human gut and migrate to these tissues and cause havoc. Ocular toxocariasis occurs due to larvae invading the eye. Leucocoria can occur due to marked vitreous clouding, usually in one or due to in one eye, or due to posterior pole granuloma. These are the things that give treatment. We already talked about diagnosis, even though most of the diagnosis concerning ocular, ultrasound scan, OCT, and others. Now, in conclusion, leucocoria is an important sign that all practitioners must be conversant with. Early recognition may save the lives of patients and reduce the burden of blindness, especially in children. Thank you for listening.
Thank you, Dr. Amos, for that wonderful presentation. By and large, I think he has done justice to the topic, and we'll leave the floor open for the participants to ask questions for clarification. Should there be comments, it's time to also make that. Thank you. The floor is open now.
Thank you, Dr. Amos, for that educating and interesting presentation. I'm aware that the cataract is the commonest cause of blindness in this environment. Yes. Then, in view of your presentation, I don't know, is there any organized screening program, maybe in Taraba State, Jalingo, that is done so that we can make early diagnosis, just as you have suggested? So, thank you very much for
The question.
To the best of my knowledge,
Yes,
apart from NGOs
who
have been
into screening eyes in Taraba here, I'm not aware government has a policy screening eyes of children, but there are NGOs that can come like White Anti-Anti
Foundation.
and recently there's another one I think they are screening eyes of children.
Sorry, sir. There's an echo. We're not getting you. Can somebody mute the other system that's close to him, please?
Okay, there's echo. They're not getting. Okay. Yes. Some NGOs.
It's better now. Thank you.
Okay. Some NGOs, I'm aware, have been doing that, and sometimes they send patients to us here. Yes.
It's okay. Thank you very much, sir. And also from the chat box, there's a question there for you, and I'll read it. In view of the need of early diagnosis of leucocoria and limited eye examination by doctors during consultation, what do you advocate doctors to do to catch them early?
I think in the course of presentation, I mentioned something about physicians and health workers being conversant with what leucocoria is. And we need to create that awareness, because in the past, even some physicians sent referrals that the patient had cataract and it was corneal opacity. So that, and somebody made a diagnosis of retinoblastoma in a 75-year-old man. So it tells us that the understanding of the ocular, that ocular feature of retinoblastoma and the retinoblastoma itself, such people probably are not very aware of it. So we need to create more of awareness, so that especially those that are in O&G and are catching the babies and the pediatricians, before they discharge such patients, please let them just look at the eye of the patient. Because like 3 months ago, a patient came, they brought a baby, and that baby was born in a hospital, and about 3 years back, and that child is completely blind from cataract. So the life of that baby, even with intervention now, we may not salvage the eyes, we may not have useful vision. So the emphasis is on us developing interest, because if we don't have the interest, we may not be part of our jurisdiction. When it comes to eye, most people will just say, yeah, nothing is there. But it's very important to catch those things very young, during birth, because the clue might be there if you are very careful. And then during antenatal sessions and probably postnatal session, emphasis should be made concerning the eyes. They should check the eyes of their patients regularly. It's not only in the eye clinics that can be advocated, because if we have a lot of blind children, then we are going to have a population that is dependent. Thank you.
All right, thank you very much, sir, for the answers provided. I don't know if we still have questions. Is there anyone who still has questions to ask? Any question? Well, I think Dr. Amos has done justice to this topic, and we're grateful for making out time to educate us. And from the chat box, I can see a comment by Dr. Nkanta. Okay. I can say there's a question: how can leucocoria be distinguished from corneal opacity?
Thank you very much for the question. In the course of the presentation, I mentioned the difference. Of course, one is from anatomical point of view. If you look at that diagram, the cornea is in front. If you have corneal opacity, one, it will obstruct the view of either the iris, the pupil may not even be visible, depending on the size of the opacity. But another way is, if the pupil is reacting, it is important to shine light. If you shine light, the pupil reacts. But sometimes the pupils do not react because of certain pathologies that have affected the integrity of the iris or the structures that regulate pupillary reaction. So, for standards, we rely on the anatomical differentiation. Pupil is right inside and is bounded by the iris. It's supposed to be round, but in some cases, because of abnormalities, you may have an eccentric pupil, like maybe iris coloboma or some other problems, maybe with chronic uveitis, iritis. You can have iris atrophy, and that might cause a distortion in the irregularity of the pupil. So those are the two ways you can distinguish them.
Okay, thank you. Yes. Yeah, so it's well understood. Thank you very much, sir. And I think by this we have almost come to the end of the EMA, considering the fact that this is the last topic. I don't know if Dr. Nuhu is still with us, because there's a question in the chat box for him. It's like he has taken a leave to attend to other pressing issues. So we're going to skip the questions. And at this point, I would like to say thank you for creating time to be part of this CMA. And before I give the CMA committee chairman to talk, I'd like to specifically commend Dr. Ebenezer Apake. He has always been an example to all of us. Whenever there is any meeting, ARD meeting, or whatsoever, you always see him there, and he will not just be there, but he will be there in good time, and he will stay till the end of the meeting. And he has also shown that, yeah, since yesterday, he has been in attendance, and today again. So we're grateful for leading by example. We hope that we will learn and be like you. And the slides will be made available, hopefully before the end of today, so that we can create time to go through them and educate ourselves better. And the committee has a plan. At initial, we intended to present 10 topics. But for the sake of convenience, we have decided to split the presentation into May and June. So 5 topics have already been taken, and 5 will be taken next month when the committee fixes an appropriate date. And for those of us who have not been able to pay the 5,000 naira CME fee, we can do well to do that. Even if you are not able to pay now, before the next time that we'll have the CME again, you can do well to pay. Now, I will now give the floor to the CME committee chairman to make 1 or 2 comments. Thank you very much. Thank you. Good morning, colleagues. I want to use this opportunity to thank everybody who has found time to be part of this CME session, the first for this year. We appreciate you taking out your time to be part of the presentation. I must say that the attendance is not encouraging, but I think, I don't know, I thought on Zoom, people will be able to have time at the convenience of their houses or where they are working to hook into such presentations, since we know the physical one is always having poor attendance, but it seems even the Zoom has not made much difference. The CME is actually an opportunity for us to update our knowledge, not only update, to learn some new things. Because personally today I've learned a lot of things too, new things, especially from the presentation on the update of management of stroke. Learned some other things during yesterday's presentation. And even on this Leucocoria, he mentioned pediatricians, pediatric doctors and obstetrician. And I can tell you that almost all our doctors, particularly working with the state government in the general hospitals, are pediatrician, are obstetrician, because they are the ones that take delivery, they are the ones that take do antenatal and postnatal care for our women. So invariably, the presentation is also for them. So if many of them were to be part of this presentation, perhaps our knowledge will have increased in terms of early detection and quick referral of those identified very early. So I encourage all of us perhaps to create more awareness on the general floor for people to find time to create. Why we actually cut off the presentation instead of the 10 CMEs that we used to do during the fiscal program was because we felt we cannot keep people for very long time via Zoom. So we created it to be short so that people can quickly participate and then go to do some other things. And I think if this 3 hours on Saturday is still much, if we think we can reduce it to 2 hours in the morning, or in the evening for more people to participate and get their knowledge updated. I think we'll look at the options and perhaps look at survey from people's opinion on the platform to see how we can improve. It's not just like a regular exercise just to fulfill all righteousness. The purpose is for us to update our knowledge. And we know that there's nobody that has it all. And we keep learning every day. I want to thank the presenters, particularly. We've reached out to them. They've taken their time, made their slides, and some of them have to leave their houses to come physically to the ICT center here for us to take the presentation. Others did their presentation in the comfort of their rooms. We appreciate them for taking out their time and then updating our knowledge on those particular topics. Our ICT people are wonderful. Since I think the past 1 week, we've been on this trying to put those programs together. I want to appreciate Dr. Bright specifically for he has been up and doing for us. We want to use the opportunity to appreciate him very well. The SOC, heavily represented in this CME committee, Dr. Unis has been up and doing too. He has been interfacing between us and the SOCs. They have been very supportive, financially, fiscally, and spiritually. We want to extend our appreciation to them for always encouraging us to do carry out the mandates that they've given to us. Once again, we appreciate you. As Unis said, probably the remaining topics we'll be able to take by next month, so we can make the presentation bi-monthly. As the case be, every 2 months we have some sessions until the year end, so that at any point we have something to keep us busy and keep our knowledge updated. Please, we encourage you to pay your 5,000 CME. It is necessary to keep the CME committee to be able to make the work going. The Zoom is not free. You pay for subscription, pay for data, and we really need that support to be able to keep those things updated. If you're going to do it monthly, perhaps it's going to be much resources for us. And that's why we may probably go for maybe bi-monthly, every 2 months. But if the resources keeps coming as we pay, the CME fee, I think it will help us and take us a long way to be able to make sure that all the necessary topics that we think is relevant for us to get updated about, we'll be able to take it much more frequently, to repeat it over and over and over again, particularly about the eye. The last presenter actually made comment about eye. Many of our doctors don't actually know the anatomy of the eye. They know it in theory, but in reality, when they come to the eye, they will see cataracts, they will see corneal opacity, they will see leucocoria, but all of them are corneal opacity to them. And I wish that Dr. Amos would probably have time in the physical aspect of it to demonstrate it to people to know that corneal opacity is on the outside. If there's corneal opacity, it's not likely for you to appreciate pupillary reaction again because the cornea is already clouded outside. The one that you're able to see the size of the opacity increasing and reducing is the one that is inside the eye. So likely it is the cataract or the leucocoria in the retina down there. We thank you once again, Dr. Amos, for educating us more and more. And thank you, colleagues. We appreciate you. Happy weekend. All right. Thank you very much. I think you can exit.